Welcome back to the Core EM Podcast. Core content for anyone, anywhere, and just in time. As promised earlier this week on the podcast, Core EM is bringing you an extra this week. This is the full recording of Sergey Motov's talk at our Grand Rounds. The title of the talk is The Evolution of Pain Management in the ED, from poppy seeds to ketamine. The audio isn't great, but there were a lot of wonderful things about this talk, so I figured we'd play it in full anyway. The big take-home points were featured in Podcast 9.0 earlier this week, so check that one out as well. All right, on to Sergey's talk.
Just first question, can you guys hear me on the back if I'm not going to use a microphone? You okay like this? Okay, if you need to, just raise your arm up so I'm going to be able to raise my voice a little bit. And I'll be okay if I'm not going to use a microphone? Okay. Okay. Pain is the most common complaint that people seek care in the emergency room. It strikes acutely, it lingers chronically, it brings a fair amount of distress to patients and the doctors as well. And if left undertreated or untreated, because of significant behavioral, social, and psychological disturbances in one's life, which lead ultimately to development of aberrant drug-related behaviors such as abuse, misuse, or diversion of drugs, and the worst part of it is development of addiction. In light of the impact that pain has on our patients, we, practicing ED physician, must be true expert in managing a variety of acute or chronic painful conditions. And, most importantly, we should take a pride and ownership in doing so. Sadly, it may not be always the case. An example, we do take care of control of airways. We proudly call ourselves intubationists because intubation is a specialty defined in skill. We have no problem resuscitating anyone, and we proudly call ourselves resuscitationists. God knows what we'll do to patients' cavities, but we take ownership and we call ourselves insertionists. We are rectalists. We are pelvicists. We are suturists. We're incisionists. We're everything. But who are we when it comes to pain management? Well, I'm going to change everything today. And as of right now, I want you to add an additional title to your amazing achievements. You are all emergency medicine algiatrists. So the next time Scott Weiner goes on the podcast says, we are all resuscitationists, sure we are. But at the same time, we are all algiatrists because pain is the most common and the most important chief complaint the patient comes to the emergency department for. And I promise you, by the end of this talk, you're all going to get a certificate of achievement. Good morning. My name is Sergey Motov. I'm from Human's Emergency Department, and I too have a general interest and passion for effective and efficient analgesia. I'm honored and extremely excited to be here today. And before I start, I want to thank Anand for inviting me. It means a lot to me to be here with you guys. And of course, thank you for being here today. We are going to talk about evolution of pain management in the emergency department. And the catchy title is From Poppy Seeds to a Ketamine. What I'm going to do, I'm probably going to go for about 40 minutes or 45 or so. I will try to leave some time for questions. And for that very reason, I'm just going to sail. And if you have questions afterwards, raise a hand after, because I know you have a break in about 53 minutes, 45 seconds, and I do honor your break time. Nothing financial to disclose, and trust me, I would love to take you to 2000 BC, when Sumerians first used extract from poppy seeds, known as opium, for treating the pain, or take it to 1500s AC, when Europe had an opioid epidemics related to Landau elixir, or take it to 19th century, when German scientist Friedrich Sturter actually synthesized morphine. And I'll be here forever, which I don't mind, but have a break. So what I'm going to do is I'm going to take you about 26 years back. And we're going to start with 1989. And in a second you will find out why this is so important, this particular year. And we are going to talk about opioids. And we're going to go to ketamine. And in between we're going to talk about a few other topics, such as we touch based on ultrasound-guided regional blocks. We'll be talking about intravenous acetaminophen. We'll talk, of course, about ketamine, and a little bit of insanity about lidocaine. And lastly, my favorite part is concept of targeted ED analgesia. 1989, 26 years ago, two doctors, Wilson and Paddington, reviewed 198 charts of patients presented to the emergency department with variety of acute and chronic painful conditions, whether or not they were medical or surgical. And what they found out was striking, that 56% of those patients did not receive analgesia while they were in the emergency department. Out of 44% who did receive, close to 67% waited for 1 hour to receive medication. So, and once again, out of those 44%, third of the patient received suboptimal dose of opioid analgesia. Others' conclusion was that pain in the emergency department is undertreated, poorly treated, and we don't give enough opioids. It was a groundbreaking study. It opened up doors to us, ED physicians, to start giving more opioids. At the same token, they increased visibility of pain. Pain became fifth vital sign. Joint Commission mandated pain scores or pain scales to assess and document patient's pain. Things gotten better, and it would have been better had it might have been stayed in the emergency department if we only used opioids for acute pain. But I want to take you jump into 1997, where American Academy of Pain Medicine and American Pain Society put together a manifesto, which is known as guidelines on using opioids in chronic non-cancer pain, in which basically they said, use it, it's safe, it's effective, no problems, no short or long-term side effects. And that was the beginning of the end. And that's how Pandora box of prescription opioids got to be opened. This massive movement of uncontrolled opioid prescribing practices resulted in colossal collateral damage in the form of abuse, misuse, and diversion. And unfortunately, so many innocent deaths were a result of this particular epidemic. Here's some data. Between 1997 and 2007, rates of prescription of oxycodone and hydrocodone went by 900% and 380%. As of right now, 2015, United States of America is the leading consumer of total world hydrocodone. We consume 98% of it. One country, 98% of hydrocodone. In addition to it, between 1997 and 2007, there were 12,000 unintentional deaths related to prescription opioid overdose. 2011, 14. 2013, 17,000. Right now it's kind of plateau, but here's a striking number. Between 1999 and 2013, 175,000 deaths were reported in the United States related to unintentional prescription opioid use, abuse, or overuse. Very concerning. I'm going to stop here, and I'm going to finish up talking about the opioid epidemics. I want to take you back to 2002, since we evolved. Early 2000s, so 2001, 2002, there was a shift, drastic shift, when it comes to meperidine, known as a Demerol in the States, known as a Ketamine in Europe and Australia and New Zealand. It was found that Demerol, known as meperidine, was not entirely good analgesic, had some weak properties, obviously weaker than morphine. And on top of it, what was found was that its active metabolite, known as normeperidine, was found to be fairly neurotoxic, meaning it was causing seizures, lots of them, especially in patients with renal failure, renal insufficiency, or elderly. On top of it, meperidine was found to have a multiple drug interactions with particular class of medications known as antidepressants, monoamine oxidase inhibitors, and selective serotonin reuptake inhibitors, which resulted in serotonin syndrome, and lots of people were dying from it. So slowly but surely, meperidine was removed from armamentarium of analgesic in the emergency department in hospitals. And I'm not going to be entirely wrong to say almost none of the hospitals in the emergency department in this country are using Demerol for pain. Demerol is out. We're moving to 2006. What's back? Evil of hydromorphone, known as Dilaudid, came back. In 2006, Dr. Chen and colleagues from Jacobi Medical Center put together a study evaluating analgesic efficacy and safety of hydromorphone in comparison to morphine. They've used 1 milligram of hydromorphone and they've used 0.1 milligram per kilogram of morphine. The results show that at 30 minutes, patients who received hydromorphone had slightly better change in pain score, which means they have a better analgesia. And when it comes to side effects, people who received hydromorphone had less pruritus. Author's conclusion was that hydromorphone is totally acceptable and great alternative to morphine. And that was the end of morphine. Because I'm a firm believer, some of our colleagues currently practicing and recently retired had this false belief or misconception that smaller aliquots of hydromorphone will provide less opioid dosages to our patients. Smaller aliquots will provide lesser dosages of opioids to our patients, which is a great, great misbelief, and it's absolutely wrong. despite years and years, let's say decades of research when it comes to opioid analgesia, we still have this dilemma. Because people are still arguing. What's the best way of dosing opioids? When it's a weight-based, or it's a fixed dose? And some people have been fighting. So let's start with the weight-based. We're going to back to 2005. Our colleagues on Jacobi, Bijor, and colleagues showed that 67% of patients had less than 50% change in pain score, excuse me, which means they had suboptimal pain relief while they were given 0.1 milligram per kilogram of weight-based morphine. A few years later, Birnbaum showed the same problem. 47% of patients had less than 50% change in pain score, suboptimal pain relief when morphine was given at 0.1 milligram per kilogram. Pectus and colleagues compared intravenous acetaminophen to morphine given at 0.1 milligram per kilogram and showed that nearly half of the patients required rescue fentanyl at 30 minutes, deeming weight-based dose of morphine inadequate. Lastly, Bailey conducted a beautiful study in pediatric patients when morphine at 0.1 milligram per kilogram was compared to placebo in relieving pain of patients presenting with the right lower quadrant. The results show that at 30 minutes there was no difference in pain between placebo and morphine given at 0.1 milligram per kilogram. So what do? We stop doing weight-based? Well, some of our colleagues went in other extremes. So we're talking about the fixed dose. And a colleague from Arizona, Sid Patamala and colleagues, they did two studies. 2012, they put 50 opioid-naive patients with a weight range between 70 to 160 kilos, and they all got 4 milligram of fixed dose of morphine. They all had identical change in pain score, and there were no correlation to initial weight. Similarly, in 2014, Patamala put together 100 non-obese, 100 obese, and 100 morbidly obese patients, and all got 4 milligram of morphine as a single push. At the end of the study, all the patients had essentially similar change in pain score, which translated into similar pain relief. And now this conclusion was, well, maybe weight-based dose is not really important. We can use fixed dose and get a great pain relief. Xie in 2014, colleague from Jacobi, used 1 milligram of hydromorphine fixed dose to 138 patients with acute pain. The results showed that all patients had a similar change in pain score. Once again, challenging the concept that maybe weight-based dose of morphine is not what we should be doing. Lastly, Chang, our amazing colleague from Jacobi who pioneered hydromorphine use in the emergency department, pushed 2 milligram of hydromorphine to patients presenting to the emergency department with acute pain. It was a great deal of pain relief. Pain dropped from 10 to 1 at 5 minutes and to 0 at 30 minutes. The worst part, about 33% of patients became hypoxic. Lowest side was 86%. That's kind of scary. So others concluded maybe 2 milligrams is a little too much. So the question is, what do we do? Is it weight-based or is it fixed dose? One of the major problems with all the studies that forgot to mention crucial word, initial. When it comes to initial dosing of morphine, I want you to remember this. It doesn't really matter what dosing regimen you choose. What matters is what you're going to do after. And for that very reason, one key word is, when it comes to opioid analgesia in the emergency department, titration is the key. Because when you titrate opioids, two things are going to happen. First, pain is going to get better. Or second, side effects will become intolerable and you will need to intervene. But usually, pain becomes better before side effect becomes intolerable. Titration is the key. Proof? 2008, our colleague from France. Morphine titrating protocol, 3 milligram Q5 minutes. At the end of the study, at 60 minutes, 99% of patients had acceptable or appropriate pain relief. Mind you, you're going to say, well, that's insane. How can you even spare a nurse for 15 minutes at the bedside? Valid point, but apparently in France it worked. Similarly, Chang, after 2 milligram was really unsuccessful, they put together 1+1 hydromorphine titration protocol. And the results showed that at 30 minutes, 77% of patients had appropriate change in pain score, or pain relief defined as a change in numerical rating score greater than 3. At 1 hour, 96% of patients had a change in numerical rating score greater than 3, which by the study design was deemed significant. Titration is the key. And this is my first key point. I'm sorry, there was a question? I'm listening. My first take-home message is, when it comes to opioid analgesia in the emergency department, please titrate. It doesn't matter what you start patient with. As far as I'm concerned, you can give him 2 milligrams. But make sure you come back in 5 minutes or 2.5 minutes and ask if the patient needs more pain medication. You give another dose. Or you can start with a 0.1 milligram per kilogram, or 0.15, or 0.2 as far as I'm concerned. but make sure you're going to reassess the patient in appropriate time interval. First take-home message. When it comes to opioid analgesia, titration is the key. 2006. It's my firm belief that nothing has revolutionized the way we practice emergency medicine as bedside emergency ultrasonography. And there's even much firmer in my belief is that ultrasound-guided regional ultrasonography is revolutionizing the way we're practicing how we're treating pain. And I believe in about 5 years from now on, this is going to be number one or primarily modality when it comes to pain management in the emergency department. Why? Because when it comes to ultrasound-guided regional blocks, it provides effective and extremely efficient analgesia. Best part, fewer side effects. In addition to it, you can reduce the rates of opioid administration or core administration to 50, 60, 70%. And in some situations, you don't even need opioids. It blows my mind sometimes to think of it. I can manage somebody's pain without opioids, but it's true. Best part, by using real-time ultrasonography, you can see the nerve. You can see the tip of the needle. You can actually follow the infusion of anesthetic around the nerve. Because you're using ultrasound, you don't need to put the patient on the monitor. You don't need to have a pre-EKG. You need to have pretty much nothing. Nurse will love you. It spares so much time. And because with the new standard of analgesics, length of stay in the emergency department is going to be exponentially shorter. At least this is some of the reasons we should be loving ultrasound-guided emergency ultrasonography. Let's look at some of the data. 2006, Mike Bly was one of the godfather of regional blocks in the emergency department, published a study of 4 patients who presented to the emergency department with dislocated shoulders. And they all had ultrasound-guided interscalene block with lidocaine. 2 had lidocaine, 2 had bupivacaine. Results, total pain control, total pain-free. No rescue analgesia, total muscle relaxation, successful reduction in the first attempt. Beautiful. Later on, Mike Stone put together a study of 5 patients who presented with an abscess, dislocation, or fracture of the upper extremity. And they've used ultrasound-guided block of brachial plexus in the supraclavicular region. Average time to decrease pain to 0 was 20 minutes. No rescue analgesia, no procedural complications. Harry and colleagues had a patient with a clavicular fracture. And instead of giving him usual perks and Vikes or even giving IV opioids, they block him. They've used 8 cc of 0.5% bupivacaine. And they used superficial cervical plexus block under ultrasound guidance. Pain dropped from 10 to 1 in about 13 minutes. Patient was discharged home, 24 hours follow-up phone call, no pain. And no opioid given on discharge. Lastly, Liebman showed that if you use ultrasound guidance for any hand trauma procedures by using forearm blocks, such as median, ulnar, or radial nerve, by using ultrasound, you can probably get a pain under control in about 5 minutes. It will take about 8 minutes to 9 to have total control for the ending of the procedures, and no immediate or delayed complications up to 3 months. Ultrasound-guided regional blocks. Let's not forget lower extremity. Haynes and colleagues from Maimonides published one of the first studies on using ultrasound-guided regional block by doing fascia-iliaca block in 20 elderly patients with hip fracture. Imagine a 90-year-old, he gets giving opioids, what's going to happen to them? But there's a 90-year-old who gets a block. Talking, had no hemodynamic compromise, life is good. By this study, 76% of patients had significant change in pain score at 120 minutes, and only 4 of them had the rescue analgesia. Francesca Biaduin later on did the same study. 13 patients, elderly, hip fracture, femoral block, ultrasound guided. 8 minutes for the procedure, 1 attempt, no adverse effect. 3 patients required rescue analgesia. Turner, pediatric hip fracture, actually pediatric femur fracture, showed that if you use ultrasound-guided regional block for pediatric femur fracture, you will have significantly longer-lasting analgesia in comparison to IV, PCA, morphine, or fentanyl, less rescue opioid analgesia, and less total dose of opioid. Boyd showed that if you have traumatic lower extremity injury by using ultrasound, you'll probably be able to kill the pain in 5 minutes. It will take about 7 minutes to do the procedure, and you would not have major side effects whatsoever. My second take-home point to you guys is embrace ultrasound-guided regional blocks. This is the future. Master it. Try it first. Master it. Become expert. And pass it to second generation. The next generation comes after you. This is the future. 2010. Big red letters. 2010 was a significant year because FDA approved intravenous acetaminophen for fever in postoperative patients and as an analgesic for mild pain or as a co-analgesic as adjunct to opioids to moderate to severe pain, mostly for post-surgical patients. That brought excited delirium to our colleagues from anesthesia and surgery. And I simply sound them still delirious with all due respect. Because some of the studies that were sponsored by big pharma companies showed that if you use intravenous acetaminophen as a part of as a part of multimodal analgesia, you can actually drop the dosage of opioids significantly. And once again, the pharmacy-sponsored study showed the range of dropping opioids were between 30% to whooping 78%. 78% reduction of opioids. Everybody went ballistic. Everybody went crazy. Let's get this medication. People just forgot one thing. It's such a weak of the weakest analgesics. And when it works alone, it doesn't really do much. All right? And subsequent studies when Euphoria initial settled down showed that yes, it does reduce opioids administration when you combine these two. But close to 20%. There's no whooping 78%. So when it comes to emergency department, there were several of our colleagues who actually decided to check whether or not intravenous acetaminophen would work as good as they say it would. So they've chosen patients with renal colic. Easy to study, pain is out of control. Let's see what's going to happen. 4 studies. 2 were done by our colleagues from Turkey, 2 were done by our colleagues from Iran. Dr. Bektas and Sergey. All trials were randomized controlled trials compared 1 single dose of intravenous acetaminophen, 1 gram given over 15 minutes, to a morphine given at 0.1 milligram per kilogram. And primary outcome change in pain score at 30 minutes. So Bektas and Sergey from Turkey showed essentially similar change in pain score at 30 minutes. Sergey's study showed that patients who received morphine required a more rescue analgesia in comparison to acetaminophen. Bektas showed rates were essentially the same. Both studies showed that those patients who received intravenous acetaminophen had significantly less side effects. Less nausea, less vomiting, none of them become dizzy, none of them drop their blood pressure. All right? Azizkhani from Iran, excuse me, showed that if you use intravenous acetaminophen for renal colic, it's not working at all. Study showed that change in pain score was minimal, if ever. Patients were in agony, and only good thing was that none of the patients who received IV Tylenol had side effects. They were in agony, but no side effects. Lastly, Masumi showed that if you give IV acetaminophen to patients with renal colic, pain is going to get better. They're going to have less side effects in comparison to morphine. 2 studies similar. 1 study shows that it works worse, 1 is better. So what do we do? So a few things I want you to understand when it comes to intravenous acetaminophen. Number 1 is insanely expensive. And it's really impossible for me to justify its use for routine analgesia in the emergency department. Between January of 2014 and July 1st of 2014, the price hike for intravenous acetaminophen in America went up by 325%. From $6 to $36. As of right now, 1 vial of 1 gram of IV acetaminophen, retail price goes between $36 to $42 per vial. Here's a comparison. 1 gram, 2 tablets of 500 milligrams of acetaminophen PO, 8 cents. Rectal suppository, less than $1, 1,250 milligrams. We're talking about 150 times increase in price of medication that barely works as analgesic. Second, mind you, studies show that there might have been increasing rates of opioid administration. However, IV acetaminophen has nothing to do with the opioid-induced side effects, which means if you give somebody opioids or co-give somebody opioids, they will puke their guts out. They will be very nauseous. And IV acetaminophen does not negate or mitigate the side effects. And in addition, the major side effect of intravenous acetaminophen was nausea and vomiting. 2012, one of the most prominent poison control centers out of Colorado, Rocky Mountain Poison Control Center, reported 10 cases of iatrogenic pediatric overdose when it comes to intravenous acetaminophen. What happened was physicians were prescribing dosages in milligrams. However, nurses miscalculated things. They were giving those in milliliters. It resulted in 10 times increased dose of intravenous acetaminophen. Lastly, it's a glass bottle, occupational hazard. You're rushing, your nurse is rushing, they can squeeze the bottle, they're going to cut themselves. right? Occupational hazard. It's a 1 gram given over 15 minutes. It's not amenable to titration because the closest you can get to second dose, it's 6 hours after first dose is given. Imagine this 1 gram given to a little, those are pediatric patients. The fair amount of wastage. And can you afford wastage when the 1 vial costs $42? No. So here's my third take-home point. When it comes to intravenous acetaminophen analgesia in the emergency department, it's not justifiable to use it. For the life of me, it's not. It doesn't reduce opioid-induced side effects, all right? It's not without a complication. There are some dosing errors, and most importantly, it's so obscenely, insanely expensive that I cannot tell you anything more than this. So when it comes to IV acetaminophen, if you have it, be very, very careful when you use it. Forget about using it as a single agent. It's technically useless. You can combine to it, but pretty much you will have to talk to your chairman after. Why use such expensive drug? If you have something better. Now let's talk about something sexier. Ketamine. Over the past 7, close to 10 years, it's been an explosion of ketamine use in the emergency department. No, I'm not going to be talking about DSI. I'm not going to talk about the controlling EDPs. I'm not going to talk about the RSI. We're going to talk about pain. In 2000, if you searched PubMed into the year of 2000, there were only 300 papers related to use of ketamine in the emergency department. 2013, 750. As of right now, close to 1,300. Half of them was related to use of ketamine for analgesia in the emergency department. When it comes to analgesia, courtesy of a good friend of mine, Dr. Ruben Schroyer, you need to understand the dosages. And when we talk about ketamine and analgesia, we are talking about low dose, also known as sub-dissociative dose, also known as analgesic dose of ketamine. And as the diagram shows, range is 0.1 to 0.4 milligram per kilogram, which is nearly 7 to 10 times less of a dose that we're accustomed to use. Most commonly practiced and published dose is 0.3 milligram per kilogram. Some of the research in the world of emergency medicine show that ketamine at this dose can be good adjunct when it's combined to opioid analgesia, or can be used as a single agent. Johansson and Jennings, they put 2 studies, randomized controlled trials, in pre-hospital care settings, and demonstrated that if ketamine is given in low dose, between 0.15 to 0.25 milligram per kilogram, as an adjunct to opioid analgesia, 2 things can happen. You can decrease opioid dose by about 35%, and upon arrival to the hospital, those patients had significantly greater change in pain score, which translated to significantly greater pain relief. Iron was able to show us that if you use low-dose ketamine, in the study they used 15 milligrams of fixed dose, they were able to cut hydromorphone dose in half. They've used 0.5 milligram of hydromorphone in addition to 15 milligrams of ketamine, and 14 patients in the study had complete pain control at 10 minutes. Galinsky, in their study, they've used 0.2 milligram per kilogram of low-dose ketamine and were able to drop their opioid rate by 28%. Lastly, just recently published study last year in Academic Emergency Medicine, Dr. Biadoin demonstrated that if you put 2 doses of ketamine as adjunct to opioids at 0.15 milligram per kilogram or 0.3 milligram per kilogram, patients do so much better when patients who received morphine alone. And 0.3 was found to be doing a little better than 0.15. So ketamine as adjunct was great. Now subsequently to it, 2 randomized controlled trials came out who compared head-to-head morphine to ketamine. 0.3 milligram per kilogram of ketamine to 0.1 milligram per kilogram of morphine. Results showed that at 5, 10, even up to 15 minutes, ketamine group did better when it came to analgesia. How about one study, Millers and colleagues, at 20 minutes, they had similar change in pain score with morphine, and at 30 minutes, Maimonides study showed they had some efficacy. As you can see, there are studies, and there are more studies coming up, that more ketamine at low dose, sub-dissociative dose, works great as adjunct to opioids, or can be used for short-term analgesia as a single agent. Here's the problem. All these studies show that even by using low dose, which is standard dose we're accustomed to use, patients had minor side effects, They were bothersome. They were short-lived. And you can see the range, 14% in pre-hospital care, to 80% in Maimonides group trial. Patients had side effects. Those side effects were directly related to a rate or degree of infusion, which means they were occurring in the first 2 minutes upon ketamine administration. What are those side effects? Nausea, vomiting, dizziness, lightheadedness, and feeling unreality. Describe, I'm quicksanding, I'm floating. They weren't entirely getting dissociated, they weren't entirely in K-hole, they were like in pre-hole. They were on the cusp of getting to the K-hole, but they really weren't there because subsequently to it, we've done something, they were able to, I believe, avert it. What we did was, and there's a practical teaching point for you guys, if you ought to use ketamine analgesic, low-dose ketamine analgesic, do not push the medication. You get this initial woof, and you're going to have people quicksanding and K-hole and having fun. Instead of it, take 0.3 milligram per kilogram, infuse in 100 cc piggy bag, give it over 10 minutes. No monitor, no pump, just give it over 10 minutes. You will have side effects. I'll show you what's the rate of it, but patients will be doing better. Subsequently to it, you can actually initiate an infusion of ketamine in the emergency department with a dose of 0.15 to 0.2 milligram per kilogram per hour. And in order for you to educate the nurses to make it simple, you tell the nurse, please take 100 milligram of ketamine, push in 100 cc, 100 ml, of normosaline, will give you 1-to-1 ratio, and start at 10 ml. Start at 15 ml, which translates to 10 to 15 milligrams. And you can titrate it up to 30 minutes, or titrate it down to 30 minutes. It does work. 2014, Goldstream colleagues put a case series of 14 patients presented to emergency department with a variety of acute and chronic painful conditions. Third of these patients were chronic opioid users, and 86% of those patients failed opioid treatment in the emergency department. They were given 0.3 milligram per kilogram of ketamine over 10 minutes. 11 out of 14 patients had significant change in pain score, greater than 3, which by statistical analysis was deemed to be clinically significant. And look at the bottom, only 2 patients, 2 had side effects. One had dizziness and tinnitus, and one felt nauseous. No quicksanding, no pre-K-hole, no psycho-dissociative effect of ketamine related. Just recently, Aaron and colleagues come up with an interesting regimen of ketamine. They've used 15 milligram of ketamine as IV push single agent, and immediately they put patient on a drip. They put 20 milligram of ketamine in a 100 cc piggy bag and let it run over 1 hour. They had 38 patients. At 5 minutes, 7 patients were pain-free. At 60 minutes, 25 patients out of 38 had significant change in pain score, greater than 3 on the medical rating scale. At 120 minutes, 26 out of 38 patients had acceptable change in pain score. But here is the problem on the bottom. Nearly 80% of patients had those bothersome minor side effects that were short-lived and that did not require any interventions. And I'm a firm believer the reason those patients had the side effects because initial dose of ketamine was pushed as an intravenous push over 1 to 2 minutes. Take-home point number 4. When it comes to low dose, known as analgesic dose, known as sub-dissociative dose ketamine analgesic, use 0.3 milligram per kilogram with a range being 0.1 to 0.4, diluted in a 100 cc piggy bag of normosaline, given over 10 minutes. If you want to put the patient on the drip, you can do the same thing or continuous infusion. Use 0.15 to 0.2 milligram per kilogram per hour and titrate up or down at 30 minutes intervals. If patient has no access, you can use intranasally sub-dissociative dose of ketamine. Dose comes to be 1 milligram per kilogram. Now, without getting too much of details, there are studies on the market that shows that you can use subcutaneous infusion of ketamine for patients who have no accesses. Try to imagine convince patient with a sickle cell crisis to be put on the ketamine infusion via subcutaneous route. I think it's a future, it may work, but it's been working. Similar doses intravenous. Okay? That's low-dose ketamine analgesic. Now let's have a little bit of insanity. So we have a little sex aside, we have a little insanity. 2012, our friend from Iran, Dr. Sulaiman Pur, published case series of 8 patients who presented to the emergency department with intractable renal colic. And guess what those patients received? They received intravenous lidocaine, the one with cardio one, in the pink bottle. Don't get confused with the one we use for the local analgesic. Pink bottle lidocaine. There's 100 milligram of lidocaine in it. They use dose of 1.5 milligram per kilogram, given intravenously as a push for patients with renal colic. Here's the result to your right, to your left. At 30 minutes, 7 out of 8% had complete pain relief. 7 out of 8 patients had complete pain relief at 30 minutes by giving intravenous lidocaine. 3 patients had a little bit of slurred speech, fun, and 2 patients felt a little dizziness. None of the patients developed an arrhythmia, none of the patients had to be rescued. Subsequently to this particular study, Dr. Solomon Poor published a randomized control trial where 120 patients received IV lidocaine and 120 patients received morphine, weight-based at 0.1 milligram per kilogram. The results show that at 60 minutes, 90% of patient lidocaine group had significantly greater change in pain score in comparison to 70% of morphine patient in morphine group. And on the bottom, 15 patients out of 120 had minor side effects, mostly dizziness, nausea, and periorbital and perioral numbness. Intravenous lidocaine for renal column. I know it's insanity, it sounds absurd, but it works, and I'll tell you why. When it comes to side effects, most common side effect is dizziness, occasional tinnitus. Sometimes can be slurred speech, which is very, very transient. Don't worry, patients are not stroking out on you, they just have the side effect of lidocaine. They have a periorbital and perioral numbness. Short-lived, about a minute to 2, nothing needs to be done. But once again, I believe everything related to the speed or rate of infusion. So if you want to use lidocaine for renal colic in your department, do the same thing. Take the pink bottle, yank the lidocaine out, push the content of lidocaine, it's 100 milligram, in 100 ml normal saline, and give it over 10 minutes. So here's the best part. I've used lidocaine, cardiac lidocaine, on renal colic patients for over a year and a half. I had about 36 patients. Half of the patient had a combination of ketorolac and lidocaine, half the patient had lidocaine. 2 patients required rescue analgesia. Only 2 out of 36. It works. It does work. Yes, sir.
When you control over something like lidocaine and ED, what do you send them home with?
That's a beautiful question. What do you usually send your patient with renal colic?
Ibuprofen and neuroleptic.
I'd use ibuprofen, no opioids, and I'll tell you why. We're talking about 30 seconds. Why isn't some patients opioids? And definitely not Flomax, right?
Because what do you send them home with if they're broken from the lidocaine?
Huh?
Okay.
Yeah, I'll tell you in a second. There's a few things coming. So this comes to lidocaine. Take a message number 5. Now we're going to talk about the coolest subject. We're almost there. I want to introduce you to the concept of channels, enzymes, and receptors. Targeted ED analgesia. I call this CERTA concept. It's actually a multimodal approach to pain management emergency department, but we're special. We do things differently, and I think CERTA sounds better than multimodal. Here is the premise of the concept. Imagine for a second what would have happened to any of your patients if you use 2 or 3 different analgesics from different classes with different target sites that can be given via similar route or different route. What could happen to your patient? I'll tell you what. Pain will become much more tolerable, and you'll probably be able to control pain at much greater extent. Because you're combining analgesic, you can use lesser dose of it. Most of this analgesic in this particular scenario are non-sedative, which means the length of stay in the emergency department will be significantly decreased, and the patient is going to feel better. Channels, enzymes, receptors, targeted analgesia. And this is what it boils down to. Because as of right now, in 2015, our understanding of pain is completely different right now. Instead of using disease and pain syndrome and disease, we should look into neurobiology of pain. All the bells and whistles, what actually is responsible for this particular pain syndrome. And I'm going to show some of the examples. We're going to start with channels. Sodium channel blockade makes perfect sense. You stop depolarization, you arrest nociception, and you block transmission. Pain stimulus doesn't get anywhere else. You arrest right there at the periphery. What we use our local anesthetic. How do we use it? Locally, clinical docs. Regionally, ultrasound-guided regional anesthesia. Don't you forget about topical preparation. Skin is a beautiful organ. It's the largest organ in the body. Works just as well. Lidocaine patches. All right? Lidocaine gel. You can use it as well. And then, obviously, you can use systemic lidocaine for treating renal colic. Don't forget about tetracaine drops when you're treating corneal ulceration. Sodium channel blockade. Works fantastically beautiful. There's another class of medication where we so often not accustomed to use in the emergency department. Antidepressants, particularly tricyclics. They have a sodium channel blocking properties. And those medications, such as nortriptyline, or amitriptyline are phenomenal in controlling pain for post-herpetic neuralgia, diabetic neuropathy, sciatica, even fibromyalgia. Beautiful medications. Calcium channels, central calcium channel. Those are not calcium channel blockers. There's not verapamilocardizine, no. Those are anti-calmantins. Neurontin, gabapentin, or pregabalin, known as Lyrica. Found great deal of use in the emergency department. And I'm firm believer you should be using this medication for patients with a chronic intractable neuropathic pain. Mind you, it will take some time to work, but you should be initiating this medication in the emergency department. These are your channels. Enzymes, COX-1, COX-2, COX-3, NSAIDs. Everybody uses NSAIDs. We can just basically cannot live with NSAIDs, so use it. But once again, don't forget about the topical version of it. We can use diclofenac gels, right? Bengate, for crying out loud. We can just use simple Bengate. It irritates the skin, but it does the thing. When it comes to receptors, opioid receptors, we cannot do anything with our opioid receptors. But this point of targeted ED analgesia, it actually pushes opioid as a second, maybe the third line of analgesics. And what I'm trying to preach is that I'm not against opioids. But if you use this approach, you may actually reserve to opioids as a rescue analgesic. Next time you have a patient with pain, I'm going to show some examples. Don't jump straight to Norco or anything opioid-containing preparation. Just keep him as a reserve. Nobody needs to suffer. But we've gained enough knowledge at this time with our understanding of pain management that we can use different medication. Use opioids as a rescue analgesic. And MDA, that's where ketamine comes in. GABA, propofol. There are cases literature that propofol can be used for intractable migraine headache. It does work. All right. We can use central alpha 1 and 2 agonists. Clonidine for neuropathic pain, for acute pain. Dexmedetomidine. It's hard for me to say because it's even more expensive than acetaminophen, but it can be used. And lastly, some adjuncts, steroids, colchicine, antiemetics, combination of metoclopramide and diphenhydramine for a headache. No opioids. We can use different medications and such. So once again, I believe if we approach pain in 2015 in the emergency department from this particular perspective, you'll be very, very successful. And what's going to make you so unique and so good, you'll be able to talk to patients because you understand what this patient is suffering from and what's involved. Simple example. Renal column. Now imagine for a second, I'll tell you, you can't manage renal column without opioid analgesic. You're probably going to punch me in the face, are you nuts? How can we do so? Well, we can, because when it comes to renal column, there are actually two receptors, one receptor, one channel they're responsible for. It's sodium channel and the COX-1 and COX-2 enzymes. And that's what you need to know. Muse are there, but they're not primarily receptor responsible for it. Because it just so happens that ureter is so rich with COX-1, COX-2 enzyme, that's why ketorolac works so well. So is sodium channel blocking agent. That's why lidocaine works so well. What lidocaine would do is it would block transmission in sympathetic afferent nerve system, which will actually lead to urethral dilatation and when assist in passage of the stone. So next time, if you have a patient with renal column and you have time and you wanted to try something new, you can combine, let's say, 10 mg of ketorolac with 100 mg of IV lidocaine and see what's going to happen to your patient. I'm not denying them opioids, but maybe for the first 5 or 10 minutes, see what they do. There are anecdotal evidence that ketorolac alone works just fine. They're anecdotal. Some of the experienced colleagues of mine are probably going to say, yes, it does. I've yet to see it because, unfortunately, out of my 12 years practicing nursing medicine, I've yet to find a single patient who will do well with ketorolac alone. But it works. But combining these two, it does work. If it doesn't work in 10 minutes, give them opioid. All right? Neuropathic pain. Okay, they will say sciatica. We all have sciatica, chronic back pain. Okay, and then 10,000 medications. But we can help them because we can rationalize. Let's say if there is not entirely crippled, they can ambulate. You can use same concept to your leg. COX. Anti-inflammatory properties and analgesia. They're out there. They're constantly firing. Sodium channel block agent is a number one drugs for neuropathic pain because they're ectopic discharges coming from the injured nerves or ganglia or roots. Nothing works better than sodium channel blockade. And that's what lidocaine patches, lidocaine cream, nortriptyline or amitriptyline as a TCAs are coming into handy. We can use anticonvulsants with neuropathic properties such as neurontin and gabapentin. Last, the patient can go to their pain management specialist. They get epidurals, either with lidocaine or steroids, and they're going to feel better. And see equation, there is an opioid. Because when it comes to chronic pain, which is the neuropathic part of it, there is no mu receptors. frankly, they're so being overly activated that there's a concept called opioid-induced hyperalgesia, which means if you give opioids to this patient, they're going to be in more pain. If they were on pre-existing condition, they were taking pain. It doesn't work. And this is what Dr. Jim Ducharme published recently in Emergency Medicine News. This is an approach to patient with postherpetic neuralgia, sciatica, fibromyalgia, and such. This is your first-line medications. Look, there's no opioids. If patient is bedridden, they're not able to ambulate, unless you're concerned about core compression, or a patient is pain is so intractably painful, you can put him on a ketamine infusion or lidocaine infusion in the emergency department. You can do this because you understand neurobiology, you understand what causes this pain syndrome, what receptors are involved. Lastly, it's probably entirely insanity to even imagine managing acute traumatic pain without opioids, right? Imagine this patient comes to your emergency department. What are you going to yell? I need 20 milligram of hydromorphone. I need 100 milligram of morphine and such. Well, it's 2015. We just talked about this targeted channels and enzyme receptors theory of mine. Well, not mine. It's been there. Imagine if you have this patient roll on his belly and you do sciatic nerve block via ultrasound guidance in the popliteal fossa right before bifurcates. You will knock the pain off entirely. You can do femoral block as well. Pain may not be as good, but you can add ketamine to it and you're golden. And here we go, patient with a fracture dislocation, open fracture, mind you, of lower tip hip, who's smiling, talking to you, texting, calling his girlfriend, telling him I'm feeling fine. He's not on PCA, morphine, or Dilaudid. He's not getting opioids. He's not getting hypotensive, hypoxic, nauseous, and such. It can be done. If it doesn't work, 10 minutes. I'm asking for 10 minutes. Seems like eternity, but you can always give opioids. But my point is only we can do things a little differently. Once again, I'm not against opioids. But we yet to find something that will be remotely resembling to it in acute settings. And they're great indications. But if we can put them on the second line as a rescue, use something different, with less side effect, early ambulation, and early discharge from ED, it would be so much better. So let me summarize everything else, and I'm going to get back to your question. Here's the 6 take-home points I want you to remember from today's talk. Number 1, when it comes to opioid analgesia, please titrate. It doesn't matter what your initial dosing is, weight-based or fixed. What matters is what you're going to do next. Titration is the key. Remember 2 things. Pain becomes tolerable, relief acceptable, or side effects becomes intolerable. Number 2, embrace, learn, master, become an expert in ultrasound-guided regional blocks. This is the future of how to manage pain in the emergency department. Please understand limitations that we talk about intravenous acetaminophen, obscene cost, weak analgesics, side effects, wastage, pediatric overdosages. Embrace ketamine analgesia at the fullest. I know it's probably the sexiest topic right now. Be smart how you do it, but if you ought to use ketamine, use it as a short infusion over 10 minutes. Don't push it. Alright? Try, at least try to use intravenous lidocaine for renal colic next time you have a patient. See what's going to happen. And last question. Try to, if you need to, try to read up a little. Try to get to understand what concept that I mentioned to you. This serve the concept. Channels, enzymes, receptors, targeted analgesia. You'll be extremely successful in managing pretty much any pain that you're faced with your patient presenting. Titrate, embrace, understand limitations. Let the ketamine analgesia rip in your emergency department. Try lidocaine, and of course, at least consider using serve the concept in an emergency department. And what I want to do, I would like to finish on an inspirational note. And there's some of the quotes that I truly admire. Number 1, you have no idea what you're capable of until you try. And that's exactly applicable to my today's talk. You've heard some of the things that you believe might be insanely insane. And you probably tell me afterwards, I don't know what you've been smoking. I tell you, I'm not taking ketamine before I do the talk. Try. And you'll be surprised what you can do and what your knowledge because of it can enhance your ability to manage somebody's pain. Number 2, by far one of my favorites quote. I'm quoting straight from Twitter by Simon Carlin. Evidence is great, but it only reaches the patient if you believe in it. I do not, any of you, want to go out of the stock straight to the emergency department and start pushing lidocaine, giving ketamine, and doing crazy things. No. I want you to be all merely skeptical. Don't take my word for it, even though I've done some research and such. Remember something I've said. Do your due diligence. Do some research. Believe in evidence. If you don't believe it, don't do it. Because this is what this is all about. You've got to believe in what you're doing in order to make patients feel better. If you don't, you'll fail. And no matter what anybody do, whatever evidence I'll show you, it's all futile. It's up to you. Believe in what you do. By trusting certain evidence, by refuting in others. And the last one. Last inspiration quote, I promise. Start by doing what's necessary. It's a human right to have their pain to be controlled in the nurse department. Take care of your patients, control their pain. By any possible cause, any possible tool, pharmacological, not pharmacological method, that's what you sign up for. That's what you pledge, that's what you oath, and that's what you do believe. Remember, you are now a nurse in medicine, algaiatrist. You've got to do this. If you start taking pain seriously and control pain in your patient, next what you can do. Do what's possible. Same concept again. Consider a bit of ketamine there. Try to understand what's wrong with IV acetaminophen. Maybe push a little lidocaine. And before you know it, you'll be mastering concept of targeted PT analgesia. And you'll be able to manage somebody's pain without opioids, at least while they're in the emergency department. And it's a beautiful, beautiful change. The way we practice emergency medicine. This is me. These are my credentials. I'll be more than happy. Do you have 2 or 3 minutes?
Absolutely.
Oh, beautiful. I'm going to take some questions. And if you want to take a picture, please call me, email me. No, don't call me. Email me. You can tweet me.